Well, good morning, everyone. I'm Jeannine Forrest, and we're welcoming you to a new program of Dementia Unplugged Care Conversations. Today, we're going to be talking with an expert about brain health, movement, and cognition. And typically, like to start with a disclaimer. All content, including any potential medical information, is provided only as an informational resource only, and it is not to be used or relied on for any diagnostic or treatment process. It should not be used as a substitute for professional diagnosis, care, and treatment. Please consult your healthcare provider before making any decisions or for guidance about a specific medical condition. The opinions expressed in the content shared by me, Dr. Forrest, and my guests are not necessarily the opinions and content of the Dementia Society of America. Thank you for listening to that. And the way we start out as well is I typically give an overview of what the word dementia is so that we're all sort of on the same page in terms of understanding. So for those of you who are new to the program, the word dementia is really considered sort of an umbrella term. Like the word cancers, there's many different types of cancers, there's many different types of conditions that present itself in a way that we name it a dementia. So the word dementia in of itself is not a disease. And the more common terms or the more conditions are those such as Alzheimer's disease, vascular dementia, can be mixed. There's Lewy body, frontal temporal, and the list goes on. But the most commonly known typically is Alzheimer's disease. There are many conditions that can mimic dementia and not necessarily progress as such, and they can be reversible, such as depression, vitamin B deficiencies, brain tumors, and so on. But needless to say, the ones that we are talking about typically are progressive and unfortunately do not have a cure at this point in our understanding in science. So that's just a little bit of a background. I do want to say that you are listening to now sort of a triad under Dementia Unplugged, and this is called Care Conversations. But there are two others I want you to be aware of. That is Dementia Unplugged Musical Connections and Dementia Unplugged Artful Insights. So please pay attention to the Dementia Society of America's website for more information on those two insightful programs. Our guest speaker today is Dr. Michael Trayford. He's the founder, director of clinical operations for Apex Brain Centers. And for those of you who may just be listening and do not have the opportunity to read this, I will read his bio. Dr. Trayford is a board-certified chiropractic neurologist and board-certified neurofeedback specialist with over 20 years of experience in the unique and groundbreaking field of functional neurology. Dr. Trayford has established a multimodal brain intensive training and rehab program built around the concept of neuroplasticity. And he can be reached later on through his website, www.apexbraincenters, all one word, .com. In terms of format, I will be speaking with Dr. Trayford and asking questions for about 30 minutes, and then opening it up to a question and answer for which you can send through the chat function. All right, and now we're going to go to our interview, and I am going to stop sharing so that we could just see us. Well, good morning, Dr. Trayford.
Good morning, Jeannie. How are you?
I'm great. Thank you. So glad you're here. And I do have to say my allergies are really acting up today. So this is live. And if you hear a few coughs, I apologize in advance. So again, we're thrilled that you're here and just can't wait to hear more about what you're doing. But I did want to open it up and start with sort of the question, just tell us a little bit about your background and what prompted your interest in this topic.
Yeah, so I came up in the physical medicine and rehabilitation world up in New York, 20 plus years ago. Undergrad and postgrad was really interested in anatomy, physiology, physics, how all of these things could be applied, biochemistry, how these things could be applied to treat the human condition, so to speak. And started out in the world of pain naturally with physical medicine and rehabilitation, multidisciplinary clinics. So you're orthopedics, neurology, chiropractic, acupuncture, massage, PT, OT, everybody working in one place for the greater good. So I got to learn to speak everybody's language. And it was really functional neurology and postgraduate education in my realm that really drew me to being able to treat the human condition, as it were, very differently. And that's with rehabilitative techniques, not just for the physical body, but for the cognitive brain as well. We would see when people's balance would improve, their attention and focus and memory would go up. And that was subjectively. And then we started measuring these things. So we start seeing the parallels between the physical body, the cognitive, mental, and emotional body, and how when you elevate one, the other follows suit. So naturally, it was an extension into the realm of brain injury, mild cognitive impairment, dementia, learning and behavioral issues, et cetera. So it was really an evolution over the years, but it was my interest in kind of bringing together the physics, anatomy, physiology, biochemistry, all under one roof, and seeing where there were kind of gaps in the system, so to speak. I'm a firm believer in a time and a place for everything, as was shown with my work in the multidisciplinary practices. But there were certainly large voids, and there still remain large voids, particularly in the areas of dementia and some other things that I just mentioned.
Wow. So it is fascinating how you had the foresight to begin to integrate this. For so long, there was such a disconnect in terms of science and medicine, in terms of the brain and the body, right? We thought it was two separate things.
Right.
And we certainly know that Cartesian sort of idea that's not accurate at all.
I think even still too, you mentioned brain body connection, and people, they think it's this esoteric concept, but it's heavily rooted in the literature from all angles. If you just Google, uh, movement and cognition, you will have resources to serve you for the rest of your life. So it's out there. We just need to be able to connect the dots. Yeah.
Mm-hmm. Yeah. So thank you about that. So my next question is, what would you see as sort of the biggest myth about brain-body health connection, brain health? Where would you start with that?
It has to be hands down, especially coming from the realm of neuroplasticity and the understanding that the brain can change until we take our last breath, for better or for worse. It's that myth that you're as good as you're going to get, or that's it. Every single day of my life, I hear people that have been told you're as good as you're going to get. Again, whether it's a brain injury, whether it's some form of dementia. Now, clearly there are neurodegenerative disorders that are degenerative in nature and constantly declining, but that doesn't mean people can't have elevations in humanism or quality of life with that. So, there are cases where people have been able to elevate function by simply changing activities of daily living and doing appropriate rehabilitation and changing their diets and so on and so forth. So, there's always a higher level of humanism, and that's what we strive for. But I will say, hands down, if somebody tells you you're as good as you're going to get, don't listen and run for the hills. Yes. Yes.
That's thank you for that. So that really has a real message of hope.
Yes.
Certainly in parallel with the Dementia Society of America's vision and mission to instill that.
Right.
Because quality of life can slightly improve, maintain, but it really requires people who understand that and don't have that pessimistic
Yes.
view. So, so in terms of that, you said it's almost a daily kind of occurrence. And so where do you see that struggle? Where is that pressure coming from?
Largely it's coming from, and I understand full well where it's coming from. There are factors of reality, liability, so many of these other things come into play when people are getting advice from largely their healthcare practitioners, but also their families as well. We want to instill hope, but we don't want to instill unrealistic hope. But the fact is, what we see on a regular basis is the bar is really set quite low, meaning people are told, this is as good as you're going to get. Your brain is not going to get better than where it's at right now, and you just have to accept that. And the vast majority of people clearly that we see have not taken that as gospel, so to speak. So there is a lot of it coming from the healthcare world. I think a lot of it is insurance driven. The fact is we only get so much time within those insurance parameters to see somebody and work with them. And clearly in short periods of time, we're not going to be able to have a massive impact on things like dementia or brain injury. It needs to be, much higher frequency of care, longer duration care, but sticking with it over time, as most people will realize that higher level of ability or function, no matter how small that might be.
Mhm. So can you give some sort of concrete examples? Someone comes in to see you. What type of strategies, recommendations to improve ADL? So what does that look like?
Sure. Everything we do, we always say you have to measure it to manage it. So we look at lots of numbers up front. We do a lot of testing, and then we use the testing to drive treatment programs. So we're doing testing of cognitive functions, attention, memory, focus, executive function, impulse control, those kinds of things. We're doing EEG, or electrical output of the brain. We're measuring that and quantifying that against normative databases. We're doing physical reflections of cognitive abilities, things like quantification of eye movements, inner ear balance centers. These things are very, very heavily related to higher human functions. And tied in. So when somebody has poor balance, they generally don't have great cognition. Look at babies and look at a senior with dementia. Do they have good balance? Do they have great cognition? No. So we need to look at the physical biomarkers as well. And motor timing is another one of those mechanisms we look at. Timing over time, neurological timing breaks down. And when we can start to rehabilitate these things towards more advanced performance, whatever that ceiling is for an individual, then we'll start to see things like attention, focus, memory, et cetera, start to increase. But our programs are 100% paying respect to the tenets of neuroplasticity, and that dictates, the frequency and intensity of care determine whether nerve cells connect or communicate or stay together. So the fact is, we have to do things in a high frequency manner, which again goes against the grain, because if people are going for therapy, they might go once or twice or 3 times a week. We're seeing people 3 times a day for 5, 10, or 15 days in a row. So we're talking 15 contact hours per week per individual, with physical, neurological, cognitive, and metabolic rehabilitation. And then introducing other methods that are really starting to show great promise in the realm of dementia, which would be things like low-level laser therapy, hyperbaric oxygen therapy, and some others. So, and clearly nutritional and metabolic protocols, higher fat diets, lower carbohydrate diets. Again, we're not saying that's good for everybody, but the fact is, the way we eat dictates our brain function. We have to address that as well. So we just go down multiple avenues and do it very, very frequently for short periods of time, kind of like, boot camps, if you will. If you ever want to get good at something, if you do it 5 days straight, you'll get better in those 5 days than you did the entire year practicing whatever it was, if it's soccer or guitar or language.
Mhm. So do you bring in the family members, or how is this in terms of strategy and learning and all of that? Is it just the person, the patient, or do you bring in other people so they're learning this
Right.
at the same time?
Yeah, clearly we tell people all the time when they come in, we say we love you, but we hope we never see you again, meaning we can get them to a point and the family, the caregivers, or even the individuals themselves can continue the progress, getting tools in their hands to complement what they've done here. But yes, particularly in the case of dementia, cognitive impairment, we almost always need a caregiver or spouse or whoever's going to be with the individual most of the time to continue. And we develop very strategic, very specific home-based recommendations. And again, people can obtain a lot. There's a lot more you can do from a home rehab standpoint these days than you could 5 or 10 years ago. We have patients getting hyperbaric chambers in their homes that are getting, whole body vibration units, which are showing a lot in the dementia realm as well. So there's lots of things that can be done depending on level of ability, financial ability, et cetera. So we can help guide them on that. But yes, we want the caregivers involved every step of the way.
Absolutely fascinating. And then how far out? So you do this program, and then is there a longitudinal piece to this where you're studying impact over time?
Yeah, we're collecting data all the time. I have a clinical outcome study that was published in 2016, I believe it was. It was a fellow who had essentially mild cognitive impairment due to radiation to the brain from a benign ependymoma. So it was the radiation that caused the dementia, essentially the mild dementia that he had. And he went from 70 years old, high performing individual, still working, scratch golfer, you name it, was just, living his best life, as they say. And within 6 weeks, he was essentially just looking at the walls in his home. And what happened was, and we recorded every piece of this from start to finish in terms of cognitive capacities, physical capacities. And as expected, the cognitive and the physical were very low to begin with. We did a 10-day program with him and showing on the order of about 30% gains in the areas of executive function, cognitive flexibility, and some others. And what happens over time now, we've been looking at that data. We have graduate students come in sometimes and mine the data for us, and we're starting to see now that we can, in many cases, start to through consultation determine, is this someone that might benefit, 10%, 20%, 30%. We still don't have the crystal ball. We can't give, exact figures to everybody, but we have the data knowledge now over the past 10 plus years of recording the physical and cognitive together that we can, start to more accurately predict what somebody's outcomes might be.
How is it different for the different conditions? So like FTD versus vascular dementia. So what do you do differently based on the underlying etiology?
Largely, again, it's the testing that dictates the treatment as well as neurological examination history. We're so multifactorial. So the fact is, when people are dealing, Alzheimer's, type 3 diabetes, right? There's a blood sugar component and small vessel damage in really most types of dementia. So we have to look at that angle. More importantly, sometimes than the neurological rehabilitation, we need to look at the metabolic functions. There's all kinds of guesstimates, but at least 50% of people with dementia have some sort of blood sugar handling issue, if not full-blown type 2 diabetes. So if we don't address that component, we're missing the boat. And a lot would say, well, once you have type 2 diabetes, you've got it. That is the case for some people, but you can always improve that blood sugar, getting down the hemoglobin A1C, getting down the fasting blood glucose through shifts to higher fat, lower carbohydrate ratios, Bredesen protocols. There's so many different methods out there, but it's all, directed in the same manner: calorie restriction, intermittent fasting. Again, we're not recommending these for everybody, but there's a lot of value. And as we see, the numbers get more stable, whether hemoglobin A1C, fasting blood glucose, the cognitive capacities begin to elevate. Now we can throw the rehabilitation on top of that because we have a system that's functioning better. And that's where they can, as we say, the sky's the limit for that individual. Indeed.
I'm going to guess, maybe without even opening it up yet to the chat, people would ask, how much does this cost? Is this through insurance? So how do people pay for your program?
Yeah, so clearly, obviously insurance is our biggest hindrance, particularly when getting into Medicare, Medicaid. There's just no allowance for things that are, aggressive treatments for things that are chronic in nature, right? Unless it's cancer or something like that. So, in terms of rehabilitation for somebody with cognitive impairment, doing something 3, 4, 5 hours a day, the insurance companies look at that and they frankly frown upon it, even though these things were done before managed care came to town, late 70s, early 80s. There were physical therapists, occupational therapists working with cerebral palsy and Down syndrome and other things, 5, 10, 15 hours a day sometimes, and seeing remarkable results. But then managed care said, no, we've got to do, 15, 20-minute sessions, 1, 2, 3 times a week. So, there are potential allowances for out-of-network reimbursement for many. We do see that. There are, payment strategies. It is, it is a fee-for-service type of scenario. We try to, in many cases, recognize that people are on fixed incomes, whether senior citizens or people that have had brain injuries. So we have different levels of understanding for senior discounts or military discounts, et cetera. So when there's the will, there's the way, and we have a lot of folks that may not appear to have the ability, but then they are able to manage through friend networks and church networks, and crowdfunding has become incredibly popular for healthcare. And it's something that people are scared to do, or even times, too proud to do. And I understand that, but more and more it's becoming necessary for people to get the care that they need in the instances where there's no other really great options out there.
Now, thank you for sharing that. But what I'm hearing is there's a whole variety of ways that people can address that financial concern. Um, when you were talking, it prompted another question. Are you seeing any variance between gender or ethnic, backgrounds, race backgrounds in terms of uh, success within your program? What's more effective? Does it break down at all by demographic?
As far as the success goes, I'd say no. The interesting thing is, demographically speaking, females are just more inclined to seek out care either for themselves or their spouses. So we see more women with mild cognitive impairment and even early stage dementia, because they're dealing with these things, whereas the men tend to put it off a little bit longer and don't want to admit that they're less than what they used to be. I think we all have issues with that, but I think the women tend to get around those issues a bit earlier. So for them, I would say the outcomes are more successful because we're often intervening much earlier in those cases. But then again, if somebody's coming in with some level of cognitive impairment, there's been something brewing under the hood, so to speak, for probably 5, 10, 15 years.
Yeah, yeah, it just doesn't typically come on automatically, right? So what would you like other health practitioners to know about the work that you're doing? Because this is not typically common knowledge in the way people are approached
Right.
with any form of death. So what would you like other practitioners who may be listening or family members to tell other practitioners?
Yeah, I would say, a lot of folks like to go right for that, what's the evidence-based approach, right? And evidence-based on the surface sounds really good, right? You want evidence behind something to prove that it's going to have a certain outcome. But the fact is, we're dealing with conditions, be it dementia, be it brain injury, be it addictions, be it whatever, that there's really no great evidence-based protocols available, right? Dietarily, we have Bredesen protocols, phenomenal systems, but the fact is we have very little in terms of evidence-based care. So it's really the pioneers in any discipline, be it neurology, be it nutrition, be it whatever, that are blazing trails and seeing really great things happening from a clinical outcomes perspective, but they're so bogged down, like myself in practice, that we don't have all day to, write papers. We have tons of data, but we just don't have the ability to do that. What we're doing is we're taking the best of the best of the research that's out there and connecting the dots. And I think that's really important because as specialized as healthcare is, people get into their discipline and they home in on that discipline. But the fact is there's so much crossover, especially when it comes to the brain. So we need to be looking at the physical therapies, the metabolic therapies, the eye movement therapies, the balance and vestibular therapies, and putting all this information together. At the end of the day, nearly everything we do is a lot of our testing procedures FDA cleared, a lot of our interventions have FDA clearances, plenty of evidence to support what we do, but it's the combination of such that is not quote unquote evidence-based. But the fact is the evidence is in the outcomes. And that's what we're first and foremost concerned with is clinical outcomes. So, I would have people question that and start to connect the dots themselves, provider or patient alike, and understand that we can't singularly address these systems. We have to do it all at once.
Thank you. I'm going to start asking the audience to perhaps add some questions into the chat. And my question before they start to come in is, what would you recommend for people? What can they do now, knowing what what sort of basic life approaches to diet and movement would you recommend for people to really start considering intentionally now?
Right. Yeah. As far as movement goes, I talk about this stuff all the time, movement and cognition. I participate in an annual conference that happens at different universities. It was at Tel Aviv last year, and Harvard, Oxford. It's going to be in Paris next year in September, hopefully, if the world is working again. But there are providers in all disciplines from across the globe coming together because they realize if people move their bodies, their brains work better. And this is really cool because there's a lot of academic, there's a lot of clinical, there's a lot getting into the realm that you wouldn't typically see at academic conferences, like people in Tai Chi and dance and yoga and Pilates. But they all come together every year and share. And really, so movement equals cognition, and movement will better your cognition. So number one, first and foremost, people need to start moving. A lot of people just don't move, and they don't move purposefully. Sit to stand, getting out of a chair under your own power is being shown to be likely one of the greatest predictors of mortality. So if we can just, and aside from blood sugar, waist to hip ratios, all those other things, cardiac markers, just simply being able to get out of a chair under your own power, activating your anti-gravity muscles, can be one of the greatest predictors of mortality. There's a lot in that right there, which means we need to be able to do these things and do them effectively. So just simply getting moving and then looking at activities that would be more purposeful movement based, like Tai Chi, like yoga, Pilates, Feldenkrais. There's all kinds of things out there, but at the end of the day, they're all neuromuscular re-education techniques that have a profound impact on our cognitive abilities. So movement is key, and we could certainly, I'm sure we'll address the nutrition stuff and some of the other questions.
Okay, I'm going to start looking at, here's a question. Sounds like, okay, this is the sounds like cost varies, but can you give a general range of an example of what it costs to get started?
Yeah, so we have what we call a day of discovery, and that's where people come in for 5 hours of all the different types of testing that we talked about, full neurological histories, reviewing any prior tests and records, et cetera. And then we go through the phases of diagnostic testing, including EEG, cognitive testing, all the physical biomarkers I spoke of. That day, that full day plus the report and everything is $950 for the day. But again, we have different levels of discount, payment plans, et cetera. And programs can run anywhere from, if we're looking at a handful of treatments, a couple of $100s to several $1,000s, depending on the frequency of care. Most of what we do is very high frequency, and those programs can range anywhere from around 2,000 to about 6,000, depending on the level of, it's really all about the level of connection with the provider, because everything we do is one-on-one based. We're not using aides and assistants. Everything is done with the doctors. So that's really important, so nothing falls through the cracks. And that includes quite a bit more than that, but that's the gist of it.
Thank you. All right, so other questions. What type of diet or diet program is most beneficial for most people to follow? I realize that each person will have some differences, and that's part one. And then part two, is there a video program that one can follow that has exercises that can help improve balance, maintain an already good balance? So
Yeah,
nutrition and video program.
yeah, to the first part of that, what happens is, like was stated in the question, is that there's no one for everybody. But we understand as humans, as American humans, we eat way too much. We eat far more than our body needs. So looking at calorie restriction, and I'm not talking extreme calorie restriction, but cutting the excess out. We eat way too much. We're a supersized society still. And with that, we're typically flipped on the ratios of foods that we eat. We have, lots and lots and lots of carbohydrates and sugar, moderate amount of protein, and very little fat. We need to flip that around so that we have a lot more healthy fats for our brains in the diet. And then we have moderate protein and lower carbohydrate intake. We understand insulin sensitivity, blood glucose, all these things, thyroid function, adrenal function, all work better when we take in less carbohydrate. Really important. Then there's extremes of that, ketogenic diets that we can those have to be monitored, and we use those for folks that are a bit more severe, so that we get their brains burning fat for fuel on a more regular basis as opposed to sugar. But again, those types of things need to be supervised. A lot of people are running into those things unsupervised and could be doing more harm than good. Bredesen protocols are the most widely accepted protocols, and there's lots of similarities there with lower carbohydrate consumption. One thing to mention is diagnostic testing. We test folks all the time that are dealing with, say, leaky guts. They have, the junctions in their gut that allow things to go in and out, into the bloodstream are too big sometimes. So what happens is we can measure certain things with, healthy gut bacteria, not healthy gut bacteria. Are people digesting fats appropriately? Sometimes they're not. So you can take all the fat you want in, but if you're not digesting it appropriately, something needs to be done. So there are laboratory tests that can help direct nutritional programs as well, which is a big part of what we do, because again, measure and manage, not just blindly go into something.
No, that makes all the sense in the world. Thank you. And the question about a video program.
Yeah, so as far as video programs, there are companies out there. I've done interviews and light classes for a company called MedFit. They've got a bunch of things online there, kind of an online university, if you will, for for physical therapists and other people in the healthcare world, but also for the general public. The key is, people need to do things to their ability level, and clearly in the realm of cognitive impairment and dementia, there's a whole realm of ability, a whole realm. So, too much too soon, again, could promote more harm than good. So you have to get some level of assessment on physical capacity, functional capacity, and engage in something that would be beneficial for you. And what I find too is that certain therapies get too aggressive too quick. So if you can't get up out of a chair under your own power, you need to work on those things first before you start, excuse me, before you start balancing on one leg with your eyes closed, right? There has to be a natural progression. So, I'll just kind of leave it at that. There are resources out there, but you have to have some level of balance, vestibular, and physical evaluation first.
Right. It's just showing again how it's all integrated. Okay, here's another question. If one believes that he has, it might be Wernicke-Korsakoff syndrome, WKS, what should be done for a diagnosis?
I'm not sure I understand the question. To obtain an official diagnosis?
I guess that's sort of, that would be my understanding. They suspect on their own.
No, if you suspect, then you need to get to the neurologist and have that diagnosed. Yeah. I think the internet is great for information. It's a double-edged sword. I really have embraced the internet, whereas we used to kind of steer people away from shopping their signs and symptoms around. But the fact is, most people have to because they're waiting months and months and months to get an appointment with a specialist. But just keep calling around, go for a longer distance if you have to, but get into somebody immediately and get that diagnosis. The sooner, the better.
Yeah. Okay. Someone's raising their hand. And let's see. Okay. So maybe the raise of the hand is just an affirmation of what you're saying. I don't see any other questions. That is, look one more time. No, oh, here we are. Here we go. Have you written a book? Other experts you appreciate, like Dr. Perlmutter?
I'm in the process of writing a book. It's actually something I've been working on in my head and finally pen to paper for the last year and a half. It's really more about brain-based addiction recovery. We work a lot with adulthood learning and behavioral issues, and clearly there's a large crossover into cognitive impairment there, damage people have done to their brains through excessive drug and alcohol use. But clearly there's a big connection between brain injury and addiction and cognitive impairment. So I just wrote a chapter in a book called Concussion Discussions about the concussion addiction connection. And then there's a lot we get into with the cognitive impairment that, that essentially perpetuates addiction. But yes, that should be out in 2022, hopefully. Yes.
Wow. Okay. Hopefully, in the midst of all this, you have time to sleep, and so I'll end with maybe this question because I don't see any other formal. So, just for yourself, people will often ask. So, how do you spend your day caring for yourself? Obviously, you're busy keeping your brain going with all of this, but what is it you do for yourself to take care of you?
Well, for me, it varies. I'm not a creature of habit. I like novelty, and novelty is incredibly important with dementia, cognitive impairment, because when you do the same thing the same way all the time, the brain isn't necessarily getting fully activated the way it should, as when we're constantly learning new things. So I kind of take that to heart and do new things all the time. But currently, my kind of usual routine, and we have resources available to us just because of the clinic, but I jump in the hyperbaric chamber at 6:30 in the morning every day for an hour. And then I row. I've just taken up rowing as something I've always wanted to do. It's a tremendous full body activity that people can do really at almost any age. You engage all of your muscles, including those important anti-gravity muscles that have so much to do with how well this is working up here. And then I eat well. I intermittent fast every day to protect my brain because I tend towards type 2 diabetes. If I let it go out of control, like back in my buffet days, it's I could eat and eat and eat. I'm a foodie. I love to eat. But the fact is, when I eat, my blood sugar gets out of control, even though I eat quite healthy. So I've been calorie restricting through intermittent fasting for 2 years, and my blood sugar sits very stable, which is, still kind of high. I'm about 95 on my blood sugar, but if I didn't control it, it would be 110, 115, 120. And, so just trying to do as much as I can. I, naturally with kids and practice and everything else going on in the world, stress is a big factor. I kind of go in and out of my meditation habits, but meditation is a big part of my life too, that I need to get back into because, that's probably the one thing that'll take care of this more than anything.
I can't thank you enough for sharing your wisdom, your insights. Yeah, this is going to benefit a lot of people on this call, and it will also be recorded so people can listen to this on future dates. Any last words you'd like to end before I go back to sharing the screen? Any last thoughts that I didn't ask you? Is there any question that was not asked or I did not ask you that you want to make sure you hit home with it?
No, I think, I could go on for hours about this stuff. I just want to thank you for everything you do for DSA, and, you're a rock star over there, and Kevin for all the great work he's done. So I just want to take the time to thank you all for everything you're doing for this community, because it's a very misunderstood community, and dementia is a big deal. It's not just one condition, and most types of dementia are actually quite treatable, if you will.
Wonderful note. Okay. So everyone on the call, I'm going to share the screen and end up with the last few slides. We did the interview. And now, of course, this is when the technology is, there we go. Yeah. So we had the questions. So the last slide here is really just a shout out to the Dementia Society of America. Thank you again for allowing me to host this program. The website for the Dementia Society of America is dementiasociety.org. It's just chock full of information, particularly helpful to family and professional caregivers. So when you have a moment, please take a look at that, and perhaps you can also donate to continue these types of programs. So on that note, again, Dr. Trayford, it is a real pleasure to see you, and I know you're a super busy guy, so appreciate really taking the time to share your knowledge.
My pleasure, Jean. Thank you so much.
You are welcome. Okay, everyone, we will see you next time. Thank you again for joining Dementia Unplugged Care Conversations. Take good care.